As I tell my story, I'd like you to keep some of these themes in mind. My story began in 1990 on a day very much like this. It was late October. I was attending a medical meeting just like you. I was 40 years old, and I woke up in the morning with my face swollen. I don't mean it was puffy. It looked like I'd been involved in a major car accident. I could breathe fine. I didn't have any problem with my airway, so I wasn't too worried about it. But over the next several months, I discovered this just wasn't a one-time event. I had developed something called chronic angioedema or urticaria. For those of you who are not physicians, angioedema is a significant swelling of the soft tissues underneath the skin or the mucous membranes. Chronic angioedema urticaria's etiology is mostly unknown. There are some familial enzyme deficiencies in the immune mechanism that can cause it. It is now known that it can be associated with autoimmune disease. It's usually treated first off with antihistamines, and when that doesn't work, with steroids, and by avoiding, if you can, the things that trigger it. In my case, the things that triggered it were physical things such as contact pressure. So if I carried a heavy shoulder bag, I would get a welt on my shoulder that would then spread down to my upper arm. If I used a gardening trowel, I would get a welt on my hand that would involve most of my hand. One time I had a yellow cough drop and got an upper airway problem. It was a pretty significant problem. And the other trigger for me was this thing called terrazines. These are substances that are found in a number of food additives, such as artificial flavoring, artificial coloring, the yellow dye, and preservatives. And this made me one of those people you hate to invite to dinner, who cannot, what are you serving? I can't eat this, I can't eat that, on and on and on. I read labels like a crazy woman. I once blew up at a woman in a supermarket who was trying to tell me about fat content in food, and I said, tell me what preservatives are in the food. Poor lady. So this went on for about 6 or 7 years, and I lost a fair bit of weight during this period of time. And I talked to the allergist about this, and I said, I think something's going on here. I'm really worried that, I've got nutritional deficiencies. And he said, don't worry about it. He really brushed it off. He said, most women would really like to lose weight. I knew his wife, and I knew that was true. But it really didn't I just kind of let it go. So this went on for some time. And after about 6 or 7 years, I started noticing I was having pain, like a musculoskeletal kind of pain in my hands. Not my fingers so much, but, right within the body of my hand. It took really very little. If I tried to open a Ziploc bag, undoing a package, lifting a container of milk. And after this went on for a month or so, I went to see a rheumatologist. And he said I had something called enthesitis. I'd never heard of it. Most of you have probably never heard of it. What it is it's an inflammation that affects the insertions of tendons and muscles into the bone. And in your hand, there are lots and lots of those insertions. And this is why it bothered my hands so much. He put me on an NSAID, and it was like a miracle. Not so much about the hand pain, but the angioedema went away. It was gone. For the first time, I'd had angioedema or urticaria every single day until I went on this NSAID. And it was gone. It helped the hands, but not nearly as much as it did the angioedema. But after about 6 months, the angioedema started coming back. And he started adding on more medications. Maybe a year and a half later, I developed pain in my left shoulder. And that was very unusual because I did not have pain in my big joints. And so I called him and he ordered some tests. And what the test showed was that I had herniated 2 discs in my neck and had a bulging disc at another level. And he tried the usual conservative things, and they weren't very helpful. And so he he sent me to a pain physician for injections in my neck. And when I saw this man, he said, well, how did this happen? We usually see this degree of injury when somebody's been involved in an accident. I said, well, I don't know, it just kind of happened. But his question made me think about it. And what I realized was that about the same time I started having my hand problem, I noticed a deterioration in my vision. I'd put it down to presbyopia, but it was more than that. I couldn't see PowerPoint presentations. I couldn't read the monitors in the airport. I was having increasing trouble in the operating room. And my way of compensating for that was to use more and more magnification. I use loupes a lot anyway, but you know, loupes are those funny glasses with look like they've got the telescope in the middle of them. And they come in different powers, and I usually used about a 2.5, and I was up to 6.5. And what happens when you use increasing magnification is the depth of your visual field becomes narrower and narrower, and when you're operating, you've got to keep your head in one spot. And some of my operations lasted several hours, so obviously it put a strain on my neck. In addition, I was also wearing a headlight pretty much all the time. If there are any surgeons in the room, you've probably worn headlights. They are not comfortable under the best of circumstances. I don't know, somebody has to do something about designing them. I think it's a disaster. Anyway, this combination of things I thought was probably what was causing the problem in my neck. And I've been telling my optometrist about my vision problems. And she said, well, I think maybe you're getting swelling in your eye, and that's why your visual acuity is off. But she hadn't really been able to do anything about it. So, and this makes no logical sense. I thought, the miracle, I'll go get Lasik surgery. That'll solve it. And so I went to a corneal specialist who did Lasik surgery. And he said, no, you're not a candidate for Lasik surgery. You have something called Pellucid marginal degeneration. And what this is a relatively rare eye condition where you have thinning of the cornea, and the cornea becomes kind of weak and sloppy, so that when I looked through it, it was like looking through wavy glass. I say that I see like an abstract artist paints. Nothing is sharp. When I could narrow my pupil, then I could see better because I was looking through less area of distortion. But he said, don't worry about it. We have a very good optometrist who specializes in contact lenses for these weird cornea diseases. And he sent me to her, and she designed a contact lens that would push back against my cornea to reshape it so that I'd get rid of all this wavy stuff. Unfortunately, remember, I've got contact angioedema, and this pressure against my cornea really caused a lot of corneal swelling. Now it was like looking through water without any goggles on. It was not a solution that worked very well. She tried a number of different contact lenses to try to sort out this problem, and nothing was working. And meanwhile, I'm getting more and more concerned about operating. I was putting off cases that I thought required a high degree of visual accuracy, visual discrimination. I was terrified that I'd be called at night to do a case with a cut nerve and cut tendons, and wouldn't be able to figure out what went where, or even what was what. And so after about 6 months of this fiddling around, I decided it was time to quit operating. And I went on disability and sold my practice. I then entered what I consider to be a very, very bleak time. It was like a winter day. It was cold, it was dark, the wind was blowing, and I was alone. I didn't know who I was, where I was. I'd started medical school when I was 20, and now on a form when it said occupation, I had no idea what to write down. Who was I? What was I? When I looked in the mirror, I didn't recognize myself. The steroids, and now I was on a lot of steroids, had made my face puffy. My hair, whether it was because of the medication I was on, whether it was because of the disease, had become very fuzzy, like somebody whose hair is growing back after chemotherapy. My skin was very fragile. If I lay on my side when I was sleeping, the skin over my cartilage on my ear would break down. If I bit into an apple, my lip would tear. I didn't know who I was when I looked in the mirror. I was amazed when people would recognize me in a store or on the street. It was a very, very difficult time. I still had a number of physical problems. Reading, I'd always been an avid reader, and now reading, though I could read, was very difficult. All those little round letters, A, E, C, they all looked the same to me. Driving at night, I really did not drive at night because at night my vision was really bad. During the day, I wouldn't drive in a place that I was unfamiliar with because I couldn't read road signs. My muscles, had started to have problems with my muscles. And for those of you who are in the audience, my CK levels were sky high. You know, that big red notice that you get when numbers are really off on a lab report, that was my CK level. And if I worked out, I could smell the ammonia in my skin from my muscles breaking down. So it was a very difficult time. And after about a year and a half of this, the man whom I'd done my hand fellowship with called and said, "Haven't heard from you for a while. What's going on?" And he was from New York, lifelong New Yorker. And when I told him the story, he said, "Well, somebody here in New York will know what to do." You all know New Yorkers, right? And so he called the head of ophthalmology at Manhattan Eye and Ear, and he said she needs to see someone in Boston. And then ultimately, through that connection, I found someone who was able to find a solution that works well for me in the kind of work I do now, that makes reading easier, that makes driving easier, though I still have some trouble with road signs. And I was able to sort of start moving on with my life. I could see a light. I could see someplace I could go. I was not just caught in this black void. And one of the things that somebody suggested I do, for those of you who are psychiatrists and psychologists, you will relate to, I hope you will relate to this. They suggested I take a seminar at the Gestalt Institute here. And my purpose in doing this was to kind of find a way to move on, to go on, to figure out what I might do next. And so I went to this weekend seminar, started on a Friday afternoon, and people sort of told their stories about, you know, why they were there. And then Saturday morning, they were getting into it a little bit more, and I'm thinking, I don't think this is where I want to be. I don't think these people have the solution for me. There was one woman who was in her 60s and had been to maybe 20 some of these Gestalt seminars and was still dealing with the issue that her mother had not loved her enough when she was a child. And I am thinking, lady, get on with it. This is not going to get you anywhere. And then there was another woman, also a physician actually, who was very overweight, and she thought people were not nice to her because of her weight. And so she would deliberately, if she was walking down a hall and meeting one of these people, she would deliberately bump into them. And I said, well, that's not a very good way to cope. I don't see why anybody would like you if you do that. And I thought, this is really not getting me much of anywhere. And they said, well, aren't you sad about what's happening? Don't you cry about it? I said, I'm finished crying. I'm moving on. And I got up and left and moved right out of the room. And that was really, in some ways, a bit of a wake-up call. I think I was at the point to move forward. And I said, no way am I staying stuck in what's gone wrong, in the things I can't fix. The only way is to move forward and try and figure out something and keep working at it. And I thank you for listening to my story.
I gave this little paper a title. It's called Philosophy Matters in Brain Matters. My attempt at wit here. In a novel I'm writing now, one of my characters says, all dying people are Cartesian dualists. This overstatement hides a piece of the truth. Illness can make almost every person vulnerable to a mind-body split. If the ill person can still think clearly, he often suffers an acute sense that his body has betrayed him, that it has gone its own way without him. The thinking, speaking ego, what I like to call the internal narrator, appears to exist independently of the afflicted body and becomes a floating commentator on the goings-on, while the symptoms of disease wreak havoc on the poor mortal body. Subjective experience often includes a self that observes illness, even though the very idea of the self remains a philosophical and scientific conundrum. René Descartes' dualism, his assertion that human beings are made of two stuff, spirit and matter, is unfashionable these days. In fact, it has been highly controversial since his own time. In 1664, the natural philosopher Margaret Cavendish wrote, quote, "I would fain ask them where their immaterial ideas reside, in which part or place of the body." Neuroscientists, many of whom, I dare say, have read little Descartes, repeatedly echo Cavendish's complaint about Cartesian dualism, one I share. And yet it is important to state that as of now, there is no consensual theoretical model for the brain-mind. The neural coordinates of consciousness, called NCC for short, which might help explain the chattering internal narrator inside each one of us, have not been found. The terms neural coordinates, underpinnings, and representations do not close the psyche-soma gap, they expose it. We have now overwhelming amounts of data, much of it from scans, but from much other research as well, and that data is racing far ahead of any overarching theory of brain function. But why is this important, and what does it have to do with doctor-patient ethics and medically unexplained symptoms? Medical knowledge is continually evolving and is always dependent on new research. But as Thomas Kuhn pointed out in The Structure of Scientific Revolutions, the course of that research also rests on paradigms, primary assumptions that lie beneath all scientific investigations, and sometimes those paradigms shift. There is increasing recognition that the terms functional and organic may be misconstrued from the start and rest upon an artificial psyche-soma divide. As I pointed out by quoting Cavendish, materialist monism is hardly new. In his introduction to Outlines of Psychology, Wilhelm Wundt, that's 1895, carefully articulates the debates between metaphysical and empirical psychology and comes down clearly on the empirical side, arguing that from his point of view, quote, "the question of the relation between psychical and physical objects disappears entirely," end quote. Biophysicists such as Hermann von Helmholtz in the 19th century were materialists, as was Jean-Martin Charcot, the French neurologist, who never ceased hoping he would discover during autopsy the brain lesions that caused hysteria. And Sigmund Freud, who coined the term conversion for hysterical phenomena, never stopped insisting that for him, psychoanalysis was a biological psychology. In Borderlands in Psychiatry, published in 1943, the psychiatrist Stanley Cobb, echoing Wundt, wrote, "I solve the mind-body problem by declaring there is no such problem. I would insist that the old dichotomies," this is 43, remember, functional or organic, mental or physical, "are not only wrong, but lead to bad habits of thinking because they lead to static and obsolete ideas and do not allow for modern, pluralistic, and dynamic ideas of matter and structure. Anyone who stops to think realizes that no function is possible without an organ that is functioning, and therefore no function takes place without structural change," end quote. This is indubitably true. Every phenomenal thought and feeling is accompanied by brain changes. In my 2004 edition of Campbell's Psychiatric Dictionary, the word psychogenic carries the following definition, quote, relating to or characterized by psychogenesis due to psychic, mental, or emotional factors and not to detectable organic or somatic factors, end quote. The definition may be saved from dualism by the word detectable, but probably not. Nevertheless, it is interesting to ask whether the distinction between psychological and physiological should be erased from medical vocabularies or whether they continue to serve some useful purpose. I am one of countless people in the world beset by an undiagnosed and medically unexplained symptom of a neurological character. I wrote a book about it called The Shaking Woman, or A History of My Nerves, that was published in 2009. The book is an interdisciplinary investigation of my symptom which draws on insights from philosophy, the history of medicine, psychiatry, psychoanalysis, neurology, and neuroscience research. Early in the book, I described the first shaking episode that occurred 2 years after my father's death. I was giving a talk in his honor. They had planted a tree there, and I'm just going to read you the description of the fit. Okay. Confident and armed with index cards, I looked out at the 50 or so friends and colleagues of my father's who had gathered around the memorial Norway spruce, launched into my first sentence, and began to shudder violently from the neck down. My arms flapped, my knees knocked. I shook as if I were having a seizure. Weirdly, my voice wasn't affected. It didn't change at all. Astounded by what was happening to me and terrified that I would fall over, I managed to keep my balance and continue, despite the fact that the cards in my hands were flying back and forth in front of me. When the speech ended, the shaking stopped. I looked down at my legs. They had turned a deep red with a bluish cast. My mother and sisters were startled by the mysterious bodily transformation that had taken place within me. They had seen me speak in public many times, sometimes in front of hundreds of people. Liv, my sister, said she had wanted to go over and put her arms around me to hold me up. My mother said she had felt as if she were looking at an electrocution. It appeared that some unknown force had suddenly taken over my body and decided I needed a good, sustained jolting. Once before, during the summer of 1982, I felt as if some superior power picked me up and tossed me about as if I were a doll. In an art gallery in Paris, I suddenly felt my left arm jerk upward and slam me backward into a wall. The whole event lasted no more than a few seconds. Not long after that, I felt euphoric, filled with supernatural joy. And then came the violent migraine that lasted for almost a year. The year of Fiorinol, Inderol, Cafragut, Elavil, Tofranil, and Melaril. Of a sleeping drug cocktail I took in the doctor's office in hopes that I would wake up headache-free. No such luck. Finally, that same neurologist sent me to the hospital and put me on the antipsychotic drug Thorazine. Those 8 stuporous days in the neurology ward with my old but surprisingly agile roommate, a stroke victim, who every night was strapped to her bed with a restraint sweetly known as a posy, and who every night defied the nurses by escaping her fetters and fleeing down the corridor. Those strange, drugged days, punctuated by visits from young men in white coats who held up pencils for me to identify, asked me the day and the year and the name of the president, pricked me with needles. Can you feel this? And the rare wave through the door from the headache czar himself, Dr. C, a man who mostly ignored me and seemed irritated that I didn't cooperate and get well, have stayed with me as a time of the blackest of all black comedies. Nobody really knew what was wrong with me. My doctor gave it a name, vascular migraine syndrome. But why I had become a vomiting, miserable, flattened, frightened, enormous headache, a Humpty Dumpty after his fall, no one could say. Perhaps because I had had one seizure before and had suffered from violent migraines with vomiting since childhood, not to speak of my unhappy stint in Mount Sinai, I did not rush to a neurologist. My headaches had often been preceded by auras with their sparkling lights, black holes, supernaturally clear vision, but also fogs, lifting feelings that gave me a sensation of being pulled upward, and just once a Lilliputian hallucination during which I saw a little pink man and pink ox on the floor of my bedroom. Very pleasant, by the way. I had febrile convulsions as an infant, and since my mid-30s have had paresthesia, or what I refer to as the body electric. Because I had, at the time of my fit, an abiding interest in neuroscience, I asked myself what on earth had caused my convulsive fit. Because it appeared to have been triggered by the speech about my father, I began to suspect a diagnosis of conversion disorder or hysteria. The shaking fits happened again. They did not happen every time I spoke in public, only once in a while, and then while climbing hard and fast on a rocky mountain trail in the Pyrenees, out of sight of my companions who were far behind me, I felt lightheaded, strange, and still panting from my exertion, I sat down on a rock to catch my breath and felt my whole body go into violent shaking yet again. I felt wobbly, drained, and unwell for the rest of the day. I began to doubt my own diagnosis. Maybe my shaking wasn't hysterical. After all, the good news about psychogenic seizures is that they can't kill you. During my medical saga, I saw a psychiatrist, a psychoanalyst, and a neurologist. My brain MRI showed nothing. The benzodiazepine lorazepam did nothing to quiet my shakes, but the beta blocker propranolol has been effective. Although occasionally I felt a buzzing, humming sensation in my body, which I take as a warning that without propranolol, I would probably be flapping like crazy. None of the doctors, they were all doctors, believed that I was having conversion episodes, and yet none of them could say exactly what I had either. After I published my book, I received letters from physicians and researchers all over the world. The book was translated into several languages. There were two kinds of letters. Doctors who were interested in some of the points I had made and either elaborated upon them or complimented me on my insights, and others who offered me a diagnosis. It is fascinating to note that I did not receive two diagnoses that were the same. I especially remember a letter from a medical researcher who was convinced my shaking was caused by a particular bacteria. I'm sorry, I can't remember the name. Testing for that bacteria turned out to be so elaborate and was limited to only a few labs around the world, so I never pursued it. So how to label my shakes: functional, organic, psychic, somatic, psychosomatic. The practical use of the word organic turns on a visible location, a brain lesion that explains the symptom. But its use also unearths ideas about what is real and unreal. The bias is, if you can see it and name it, it's real. If you can't, it's not. New technology has altered visibility. Oxygenated blood flow can be seen on scans, but blood flow is hardly a lesion. In popular culture, it has become common to talk about depression now as a chemical imbalance, as if balancing a person's neurochemicals, whatever that might mean, can resolve the complex reality of depression. Schizophrenia has also become an organic brain disease, although its cause is unknown. The reduction of psychiatric illness to brain processes comforts patients and their families because they appear to confirm the physical reality of their illnesses. Cultural and medical hierarchies about the psychic or physical nature of disease infect our attitudes toward them. Unfortunately, chemical imbalance and organic brain disease don't mean much, despite the fact that the brain is obviously at the bottom of these ailments. Epilepsy is classified as an organic disease, psychogenic non-epileptic seizures, or PNES, as a functional disorder, because no physical site of injury can be found. Nevertheless, the two are often confused. EEGs may be ambiguous, and not all epileptic patients have revelatory MRIs. The neurologist who suspects PNES must become a medical detective, relying on a clue from her patient, such as a seizure triggered by some powerful emotional event. Then again, there are epileptic patients who can seize after a shock or a strong emotional experience too. The doctor may note the failure of medication to stop the fits. Of course, medication sometimes also fails to cure genuine epileptic seizures. And because some epileptic patients also have PNES, the picture can grow pretty murky. The Treatment of Epilepsy, Principles and Practice, 4th edition, 2006, has a chapter on PNES. The author of this chapter adopts a confident, authoritative tone, no doubt intended to buck up budding neurologists who might be worried about misdiagnosis. In a chapter labeled Psychopathology, he declares PNES a psychiatric disorder and rehashes the DSM criteria for somatoform disorders, factitious disorders, and malingering. Somatoform disorders are, quote, the unconscious production of physical symptoms caused by psychological factors, end quote. He then emphasizes that the patients are not faking, unlike the factitious folks and malingerers. He makes no comment on the controversies that surround the DSM's metamorphosing categories or its lack of etiology. He mentions that sexual trauma or abuse may play a role in psychogenic seizures, and then at the very end of the small section, the reader is told, quote, from a practical point of view, the role of the neurologist and other medical specialists is to determine whether organic disease exists. Once the symptoms are shown to be psychogenic in nature, the exact psychiatric diagnosis and its treatment are best handled by a psychiatrist, end quote. In other words, send the patient to the other ward. Under the following section called Management, the reader is told how important it is for the neurologist to communicate the psychogenic diagnosis using words such as psychological, stress-induced, and emotional. I quote, the physician communicating the diagnosis must be compassionate. Here's the parentheses, remembering that most patients are not faking, end parentheses, but firm and confident, parentheses, avoiding wishy-washy and confusing terms, end parentheses. The author is clearly unfazed by any philosophical difficulties involved in opposing organic to psychogenic. He does not bother to say that emotion and stress are also organic processes, albeit not ones connected to specific locatable brain damage. His discussion is inherently dualistic. Rounding up his chapter, he names several fashionable syndromes that may be thought of as partly or entirely psychogenic. The words entirely psychogenic are followed by parentheses, inside of which we find the emphatic explanatory phrase without any organic basis. The implication is that they are somehow non-organic. But how can that be? Are psychogenic seizures unreal, ungrounded, and immaterial? Are they brought on by supernatural, spiritual forces? The syndromes he mentions include fibromyalgia, fibrositis, chronic fatigue syndrome, and irritable bowel. Note the use of the word fashionable. The word fashionable is a put-down that effectively turns these syndromes into flimsy, effeminate, short-lived phenomena similar to this year's skirt lengths or a new rage for open-toed shoes. Fibromyalgia, fibrositis, irritable bowel, and chronic fatigue are all diagnosed far more in women than in men. The ethical implications of my semantic analysis of these passages are not difficult to extrapolate. It is not that distinguishing between epileptic and non-epileptic seizures isn't important, or that their etiologies aren't different. Of course they are. It is that the author's supposedly neutral language is colored by a philosophically naive, hierarchical conception of the physiological over the psychological. He does not even tip his hat to the truism that organic brain processes accompany all subjective psychological experiences, nor does he cite research on the neurobiology of emotion and its implications for psychiatric illness. During emotional shocks or trauma, the body goes into a state of emergency, and there is considerable evidence that repeated shocks create lasting physiological changes in cortisol levels and hippocampal volume, to give just 2 examples. And epigenetic studies, this is very interesting, are beginning to uncover the effects of stress on gene expression. I will cite a single example, a 2010 paper in Biological Psychiatry called Epigenetic Transmission of the Impact of Early Stress Across Generations. The study exposed male mice to repeated and unpredictable maternal separation, which had the effect of altering the profile of their DNA methylation, the modification of a DNA strand after it has been replicated. Comparable changes in methylation were seen in their offspring, even though they were reared normally. To make it short, stress altered the pattern of gene expression not only in the parent, but in the next generation. It's Lamarck. It's kind of amazing, right? Anyway, the traumatic stressors appear to play a role in conversion disorder is well known, but poorly studied. And yet the burgeoning research being done in affective neuroscience warrants, at the very least, a careful reevaluation of what we mean by functional illness. Lurking beneath our author's use of the word fashionable, alas, is an implicit sexual bias that dismisses incompletely understood syndromes as all-in-your-head feminine complaints. The widely held belief that psychogenic or conversion phenomena are up to 10 times more common in women than in men, a statistic cited in the DSM, only increases the odds that sexism plays a role in the characterization of psychogenic illness. The truth is, of course, that it's true with women in non-combat populations, but conversion seizures have been recorded in the largest numbers among combat soldiers. Weinstein has a conversion chapter on conversion that goes all the way back to the Civil War, most of whom, of course, have been men until very recently. The trenches of World War I were seething hotbeds of psychogenic illness. My guess is that the horror of helplessness in soldiers who are literally stuck in a hole as they watch their fellows being blown to bits goes a long way in explaining why shell shock, hysteria, became the illness of the Great War. And it is not over. Many veterans of Iraq and Afghanistan also suffer from conversion seizures. The problem is getting the Veterans Administration to recognize their suffering as real. A letter posted online in 2007 by a veteran of both Iraq and Afghanistan may stand as exemplary. The man had myriad symptoms: headaches, a recurrence of odd smells, shortness of breath, fatigue, and seizures. After an EEG, he was told that his seizures were non-epileptic, the result of conversion disorder. I quote, this is the veteran, "The head of neurology, Dr. Sams, came in and stated that everything was in my head and it was all PTSD related," end quote. The patient was discharged and told to get physical therapy. It is not odd that he was puzzled. This is the veteran again. "If it is mental," he writes, "then why am I going to physical therapy for it?" It is highly unlikely that the neurologist author of the textbook chapter on PNES would admit to naive dualism, sexism, or bias against emotionally produced illness. But I suggest they are all present nevertheless. Historical context provided by medical history may serve as a corrective to these underlying prejudices. In the first of 15 lectures he gave at Harvard in 1907, The Major Symptoms of Hysteria, Pierre Janet confronted the ambiguous character of what would now be called psychogenic ailments. The symptoms of the disease, he says, quote, "are exceedingly numerous and its limits very vague." He acknowledges that contemporary authors do not agree about what falls under the term hysteria. And then he goes on to articulate a far broader ambiguity that every doctor and every patient should bear in mind. This is Janet. This indecision generally surprises young people. You think that in science, things are perfectly definite, and you are very much astonished to find indecision in your masters. In reality, definiteness does not exist in natural phenomenon. It exists but in our systematic descriptions. It is the men of science who cut separate pieces out of a whole that nature has made continuous. Physicians, it is true, may agree in certain cases when there is a distinctly visible objective phenomenon characterizing such and such a lesion. But unfortunately, we have nothing of the kind at our disposal to define diseases of the mind. End quote from Janet. Janet was a neurologist and a philosopher. His Kantian inheritance is clear in a statement that it is we who cut the world into pieces. We cannot leap out of our minds, become omniscient, and see the world as it is. Objectivity in science is not an absolute, but one determined by consensus, as Janet points out, an agreement about a lesion, for example. And yet, those same objective categories change over time. In 1907, hysteria had not yet been handed over to psychiatry. Charcot, with whom the younger Janet worked at the Salpêtrière Hospital in Paris, regarded hysteria as a natural phenomenon, period, with an unknown physical cause. Hysterics were not insane. For Janet, hysteria had a psychobiological character caused by a mental dissociation of particular functions from others through what he called, quote, a retraction of the field of personal consciousness, end quote. What is missing, Janet argued, is, quote, the faculty that enables the subject to say, it is I who feel, it is I who hear. Specifically addressing hysterical tremor, Janet writes, quote, in some rare cases you can find behind the tremors, as behind the tics, the existence of a fixed idea separated from the consciousness. Janet's idée fixe was an idea that had been unconsciously transformed into a somatic symptom. Whatever its cause, a conversion seizure is involuntary and real. With scans, it is now possible to see visible asymmetries in the brains of conversion patients that resolve themselves when the affliction ends. This, of course, does not explain what conversion is, even in neurobiological terms. It simply points to organic changes. In The Shaking Woman, I quote a paper published 99 years after Janet's lecture in Neurology by Trevor Hurwitz and James Pritchard, this is 2006, quote, conversion reactions are fixed beliefs of somatic dysfunction arising from psychological distress that control cortical and subcortical pathways to produce patterns of loss or gain of function that are not organic in the conventional sense, end quote. This is no more precise than Janet's description in 1907, and a good deal less thoughtful. They also lift the term fixed belief directly from Janet. I also quote a 1998 paper in Psychiatry Research in which the authors are more straightforward. Here's the quote. The question of how special psychological processes transmute into neurobiology has yet to be answered, end quote. I point out that this is exactly what Freud asked and hoped to answer in 1895 when he was working on his project and then, of course, was forced to abandon it. How do we ethically frame the murky territory of non-epileptic seizures? The veteran who, after an EEG, is summarily told his symptoms are all in his head and sent off to physical therapy without further ado, has clearly been treated unethically. The problem is not the diagnosis of conversion necessarily, although I wonder about the man's olfactory hallucinations and whether his physicians may have missed something. The problem is that his subjective experience of suffering has been dishonored by cavalier treatment and, frankly, ignorance about the organic character of what is now called PTSD. The most terrible thing that can happen to a patient is to be robbed of the dignity of his own narrative. Every illness has a story because every illness is a dynamic, not a static phenomenon that exists in time. Therefore, static, mechanistic models, whether in neurology or psychiatry, inevitably distort the character of any illness. Patients must be allowed to tell their stories, and they must be listened to as experts on the nuances of their own symptoms. Their case histories are valuable as documents of an unfolding story, and no two narratives will be identical. But there is also a therapeutic value in telling itself, which is related to the all-important question of agency. Every illness chips away at this aspect of the self. The disease or symptom creates feelings of helplessness, vulnerability, and a general sense that one lacks control over one's own life. And even when the disease or symptom persists without resolution, the sense of agency can be strengthened. In Injured Brains of Medical Minds, A View from Within, edited by Narinder Kapoor, a compilation of physicians' self-reports on their neurological disorders, a general practitioner, John Lasik, who developed epilepsy late in his life, meditates on questions of illness and agency. This is quoting Lasik. Understanding, he writes, does not necessarily change the reactions, but it makes a difference to their severity, end quote. After stopping his medicine because he had been free of seizures for 3 years, he had another tonic-clonic convulsion that was followed by a depression. However, he writes, because of the knowledge I had gained, this depression was not accompanied by the feelings of hopelessness. And even the funny smell that returned together with the emotional dread wasn't nearly as disturbing because I understood what was happening, end quote. His symptoms are identical. He uses the words depression and dread to describe them, but he acknowledges that his feelings have nevertheless been transformed by an increased understanding of the nature of the disease. Knowledge creates a change in him, a change that I would argue is psychobiological and related to a greater sense of agency that arrives with understanding and narrative mastery. When I learned to accept my migraines as permanent fixtures in my life and to practice biofeedback in the face of them, my life changed and my pain lessened. The change is not just mental, of course. It is physical or psychobiological. There are increasing numbers of neuroimaging studies on depression which demonstrate that the hypoactivity of the prefrontal cortex seen in depression becomes normal after remission, when a patient has been treated with either fluoxetine or placebo. Placebo is, of course, a top-down effect that involves beliefs that trigger the release of endogenous opioids in the brain. Exactly how belief, an idea, transmutes into physiological processes wasn't understood by Janet, and it is not understood now. In all events, there is increasing evidence for similar prefrontal normalization after talk therapy, which involves precisely the understanding Lasik cites as having altered his relation to his epilepsy. And this brings us back to the internal narrator and Descartes' cogito ergo sum, that powerful, subjective, if illusory, feeling of an I that exists beyond the body. What human beings have, that animals do not is a highly developed reflective self-consciousness that makes it possible for us to alienate ourselves in symbols. We can represent ourselves to ourselves in language. We can say I, and that I can tell a story. And how the story of an illness is told is crucial to how it is lived. I cannot emphasize this enough. Looking back on his life, John Lysiak remembers not being able to do what other children could. The village fair, he writes, that filled everyone with wonder and excitement made me feel uneasy, and I was never happy to go on the Ferris wheel, end quote. Nor was I. I simply couldn't understand why the rides that caused intense nausea, dizziness, and disequilibrium in me seemed so pleasant to other children. The neurological hypersensitivity, visual, auditory, tactile, olfactory, that arrives with migraine and or epilepsy is not all bad. I, for one, am not willing to trade in my childhood sensitivities and raging pains, my many auras followed by headache, or even my peculiar epileptiform, maybe not pseudo-seizures, for a more normal trajectory, because these events are not only part of my story, they have been crucial to my life as a writer of both fiction and nonfiction, not in content I'm talking about. I have sometimes wondered if I would have become a writer had I not had my particular neurological disposition. But my pathological hypersensitivity, let us call it by its right name, has also served me well, because I've been able to frame this quality of my being to my advantage through a self-narrative that recognizes strength in what is often regarded as weakness. Moreover, my insatiable reading in many disciplines and my subsequent thinking about the question, what are we, have brought me what can only be called compensatory joy. If you can't cure yourself, you can certainly learn as much as possible about what ails you. Philosophy matters because it informs diagnosis. I think it may be time for functional and organic to go the way of humors and be replaced by other more subtle understandings of biological, psychobiological processes. In the face of so much that remains unknown about brain function, intellectual humility matters. And as a physician, intellectual humility may involve explaining to a patient that you don't know what is wrong with him or her. It may mean being wishy-washy and ambivalent rather than firm and confident. It may mean recognizing implicit prejudices in yourself against psychogenic and or emotional psychiatric illnesses as somehow effeminate and less real than a brain lesion. As a young woman with debilitating migraines, I was at times treated with condescension and exasperation by neurologists and medical professionals. Although some empathy in one's doctor is certainly desirable, an ethical position requires respect above all. The simple recognition that the patient in front of you has an inner life as full and complex as your own. Thank you very much.